Lecture 23.
And also today, get in and have a course evaluation. The items of questions are in today's lecture. So let me go ahead and get started. Okay, the term cranial nerves comes from the fact that they use the central nervous system by foramen in the cranium. So they all originate from the cranium in contrast to the spinal nerves and go out to mostly innervate structures in the head, but not all, as you'll see. Some of them innervate viscera and other structures. Some of them are motor, pure motor. Some of them are pure sensory, but most of them have both sensory and motor tracts in them. And they are designated by Roman numerals, traditionally from 1 to 12, and a name. And almost part of every part of the kind of steps of getting through any AP course is to learn these cranial nerves. If you're in the lab, you've already done it, but for the lecture too, I want you to know the name, number, and function of each of the cranial nerves. So there's many mnemonic devices to do this. Some of them I can't even say in public, but you'll see I refer to one or two. This is this is two actually very tame mnemonic devices compared to the majority. So 1 through 12, and their names, olfactory, optic, and so forth, and the mnemonic devices on Olympic towering tops of foolish Austrian gruvines and hops. These have changed because, interestingly, the names of the nerves have changed with time. We used to call the accessory the somatoaccessory, or even spinal accessory, and we used to call the vestibulocochlear the acoustic. And so these devices have changed a lot in the last 10 years. And also there's devices to remember, or little sayings to remember whether they're sensory or motor, and this is one of the many. They've probably given you some others in lab. Some say merry money, but my brother says big, and that changes. The next word changes depending on your inclination. Brains matter more, and I'll let you do with what you want. This is our anatomy book summary of these structures. They're ganglia and then branch and so forth. I don't need you to know the foramen for sure, and I won't even refer to those. I do want you to know whether they're sensory and somatic, or sensory or motor mixed, and I will tell you a little bit about each one. I'd like you to know as we go through the different slides. Okay, so let me start out with this figure that shows you the nerves on the ventral part of the brain. And if you're, again, in lab, you've already seen this, and probably something like this will probably be on the lab final. I don't have any figures. I'm not planning on having any figures in the final exam for the lecture, but this is the location of the nerves for which you'll have to know for the lab at least. So the cranial nerve number 1 is the olfactory. Most of these are bilateral at least, and I'll talk about an interesting difference in that, but most of them have a branch on each side of the cerebrum. The optic, number 2, and it crosses its decussation is called the optic chiasma. We'll have more about that in a second. Ocular motors, number 3. Number 4 is the trochlear, which is little small nerves right behind the largest cranial nerve, which is the trigeminal, which is right a little bit posterior to the trochlear. And then abducens, cranial nerve number 6, facial 7, vestibulocochlear, that's one we used to call the acoustic, was a little easier, number 8, and then 9 is glossopharyngeal, 10 is vagus, large nerve on the side of the medulla, 11 is the accessory, which we called spinal accessory and all kinds of other names, and finally the 12 is the hypoglossal up here on the more superficial medulla. So we're going to go through each of these and talk a little bit about their nuclei, where they are, and then their function is. So the olfactory is pure sensory. It's the ganglion cells of the retina are the beginning of this nerve, and we went through the structure of the retina and how it's composed. So the olfactory, no, I'm saying that wrong. The olfactory is the bipolar cells of the olfactory epithelium, and the cell bodies are here in this olfactory bulb. And these are bipolar neurons, as you remember, and they're sensing the odors or the chemicals that are in the nasal sinus. It's kind of interesting because all the other cranial nerves are one nerve on each side of the brain that goes through the cranium. When they finally the histologist got to this is not a single nerve, and they call it a forest of nerves, but every one of the bipolar nerves goes through the cranium. So the olfactory, number one, is actually a whole family of nerves, to be very exact. Well, anyway, they have their cell bodies in the olfactory bulb, and then the tract goes all the way to the olfactory cortex. And another interesting thing about the olfactory nerve is it does not synapse in any nucleus like the thalamus. So it's the only cranial nerve that goes directly to the cerebrum without some other secondary or tertiary level. So it goes from the olfactory bulb all the way to the olfactory cortex, which we've pointed out is in the temporal lobe. The optic nerve, the second one, of course, is what I started to say before, originates from the retina, from the ganglion cells of the retina. Each of these nerves carries a million sensory fibers, so there's a tremendous amount of nerves going through this tract, all coming from the retina. These nerves travel through the optic nerve and then get to the optic chiasm, where some of them decussate and some of them don't. The more medial fibers, as you can see here, do cross to this side of the cerebrum, but the lateral in each case stay on the same side, so it's kind of an interesting arrangement. From the optic chiasma, the next part of the course is called the optic tract, and then they go to the thalamus, part of the thalamus called the lateral geniculate nucleus, not that I care, but they go to the thalamus where they synapse, and then the next order of neuron goes to the visual cortex, which is in the occipital lobe. So because of this unique arrangement, each hemisphere receives ipsilateral lateral fibers. In other words, on the same side it gets a lateral information from that eye, but contralateral information from the medial portion of the other retina. Kind of interesting. So in each part of our brain, we're going to talk about hemispheric dominance and the value and problems that exist by having two hemispheres, or actually it looks like two brains, as we'll discuss in the next lecture. It's kind of interesting, but each hemisphere this way does get information from each side of our system. So those two nerves, 1 and 2, both go into the end up going into the prosencephalon, the first part of our brain, or cerebrum. And then the next few, the 3 and 4, originate from the midbrain, the mesencephalon. As you can see here, they come right here before the pons area. And number 3 is ocular motor. There's a whole series of cranial nerves, and again, this shows how precise we try and regulate our visual sense. But there's three of the cranial nerves that regulate our eye muscles, and the first of the 3 regulate, as we say here, provide motor output for the superior inferior medial rectus and the inferior oblique. So of the 6 eye muscles, 4 of the 6 are controlled by the ocular motor number 3, or number 3 cranial nerve. Also, there are fibers there from the autonomic tract, parasympathetic part of the autonomic nervous system that control lens and pupil accommodation that we talked about in the visual system. Several of these nerves, and it's a pretty small point, I just put it in here for completeness, but several of the cranial nerves have some proprioception because these muscles have some very small of the motor spindles we talked about before that give some control of their kind of how precise they are, their precision. This is such a minor part of the total nervous character of that nerve that even though there's some sensory, we still call it a motor. So that's true of number 3 and number 4 and some of the others. So if, you know, in exams and my exams or in exams in any system, whether it be medical school or whatever, they will never say this is mixed because they just claim this is such a minor component. So everybody says this is pure motor because that's 99% of what it does. And the same about the trochlear. It's a cranial muscle from the midbrain that goes to the eye muscles. And in this case, the one eye muscle, the superior oblique. And you can tell by its name which muscle it goes to. If you know about the trochlea, that is required for the activity of the superior oblique because it turns the eye and it allows this, it has to have kind of a pulley system to do it. So anyway, that's where the name of this nerve comes from. Again, a very small amount of proprioceptive capability, and so they just call it a motor nerve. So that's 3 and 4 that come from the midbrain. The next few cranial nerves originate from the pons area, as is pictured right here. And the first one is quite large. It's by far the largest of the cranial nerves. It's called the trigeminal, and the name comes from it gives generation, if you will, to 3 different branches, each of which is very significant. This is a nice figure from Martini's book. So there's 3 different branches that come out of the trigeminal. One's called the ophthalmic, which cleverly goes to the eye surface and scalp, forehead, and upper eyelid. So you can see its arboration here in the nice figure, and provides sensory information from those areas. So a pain of the eye would be manifest through this. Maxillary goes to the maxilla, so it's pretty easy to remember. And so it provides pain information from the upper teeth and from the face and palate and lower eyelid areas, you can see right here. So surface pain as well as teeth pain. And finally, the mandibular goes to the teeth in the mandible, or lower teeth, if you will, and gums and lips and so forth. So a lot of the facial sensory material or information comes from this trigeminal nerve. When you go visit the dentist, then he very gently sticks that 20-inch needle into your jaw to give you Novocaine. What he's trying to hit is right here if he's going to work on the upper teeth, or down here if he's going to work in the lower teeth. And so anyway, he injects Novocaine, a local anesthetic, in those 2 areas to block the tracks of this wonderful nerve. And that's why you feel numbness in your tongue and this whole side of your face with that Novocaine in. Goes to that trigeminal branching. There is definitely motor activity, significant motor activity of trigeminal. It's responsible for the muscles of mastication, which you do know, the masseter, and the temporalis that both lift the lower jaw. So anyway, these are controlled by this trigeminal. Okay, the abducens is cranial nerve number 6, and that also comes from the pons area, from right here. And it is motor to the last eye muscle, the lateral rectus, which
they've cut off so you can see the rest of the eye muscles, but it's represented right here. So the most lateral eye muscle is the abducens. It's also has some extremely minor sensory role, so the only thing that one should remember is more eye muscle activity. So that's number 6. Number 7 is called the facial, and that also comes from the pons, and it's mixed. Definitely there's facial muscles. It's responsible for the control of facial expression, they usually say, hence the name facial. It also is responsible for saliva formation and crying and taste. Some taste comes through this facial nerve, although there's another nerve that also innervates the tongue and modulates or carries taste information. So that's cranial nerve number 7. Number 8, that finishes the innervation cranial nerves coming from the pons. So we had the 2 from the prosencephalon from the cerebrum, the 2 from the midbrain. There's 3 from the pons, and the last 4 or 8, 9, 10, last 5 come from the medulla. And the first is the vestibulocochlear that keeps changing their name. So we used to call it acoustic, which of course refers to its coming from the cochlea and carrying sound information, but it does innervate the vestibules that have the ampulla and the semicircular canal. So it does carry vestibular sense or position sense. And so now we call it probably better the vestibulocochlear nerve or cranial nerve number 7. As you can see, it goes right into actually it goes right to the top of the medulla. So its nucleus, the vestibular nucleus, is in the medulla. So anyway, that's 7. That was 8. Okay, number 9 is glossopharyngeal. Glosso, the term glosso refers to tongue, and so tongue and pharynx is 9. It's sensory in the tongue and also the tonsils, and controls swallowing. It comes from the medulla, and the swallowing center is in the medulla, so that makes sense. So it controls all the sphincters that are required for swallowing activity. You'll notice that it also has a branch that goes down into the thorax and innervates what we call the carotid sinus. We were talking about this at the beginning of second semester. And right in that carotid sinus are 2 stretch receptors that monitor blood pressure. So part of the critical function of the glossopharyngeal is to conduct information about our blood pressure that comes from baroreceptors or pressure receptors in the carotid sinus. So that's another cranial nerve function. So that's 9. Number 10, we're going to talk about all the way through second semester. A good way to remember what 10 does is the vagus comes from a Greek term. You can think of vagabond, if it helps, that means wanderer, like a vagabond wanders around the area. And the vagus is certainly a wandering nerve. It covers almost all the viscera in the thorax and even abdomen, so it does a tremendous amount of innervation, both sensory and motor. There are both sensory fibers coming up the vagus and motor fibers going down the vagus, and all the way through second semester we'll be talking about vagal efferents and vagal afferents that play a big role in visceral function. So motor, swallowing and speech is part of it, but also all types of automatic, those are somatic or voluntary activity. There's all kinds of autonomic control of the cardiovascular system, both pressure, both the strength and heart rate, strength and contraction, heart rate, respiratory function through the innervation of the diaphragm, and all types of innervation of the gastric system, from motility through digestion, through release of hormones and all kinds of things we'll talk about. So tremendous amount of autonomic nervous system of the viscera, and you can see branches going all the way down into the pelvis. And finally, our visceral sensation is dependent on this. So gastric pain and pain from the viscera is conducted through this nerve also. So that's cranial nerve number 10. And that, of course, it comes from nuclei in the medulla. So the cardiovascular center and respiratory centers that are in the medulla come from this nerve. Okay, the next one is 11. We used to call it spinal accessory. Now they're calling it accessory. It's kind of an interesting nerve in that, as nicely pictured here, part of it comes from cervical branches, spinal nerves in the cervical region that go up through the foramen magnum and then come back out through the cranium. So there are medullary branches that control this, or that feed into this nerve, accessory nerve number 9, number 11. But there are also nerve inputs or branches that come in from the spinal nerves and through the foramen magnum and then out the cranium. It also provides motor activity to the larynx, some muscles in the neck, sternocleidomastoid, trapezius, and there's a significant amount of proprioception, but again, this classically is called a motor nerve, so they don't think it's a significant role of this accessory. Finally, hypoglossal, again, the term glossal means nerve or tongue, and it gives motor activity to the tongue and sensory or position activity to the tongue, but again, that's pretty minor, so it's classified as a motor nerve, and it originates also from the medulla. It's right on the superior part of the medulla. Nice picture of it right there, and then accessory right here. So those are the 12 cranial nerves, and kind of the level that I went through them is what I'd like you to understand. Okay, so now we're going to go and get started in the next lecture. I don't expect to finish it, but I can get started today and won't have so much to do next time. Also, I won't give you time to do the evaluation, so I'm not going to use anywhere near the full time. So this lecture, the material from this lecture is again, won't be found in Gorham and Volpe, but is scattered all over the place. It was in earlier physiology books, but like I said, when I started neuro, we're taking more and more critical information in neurophys out of classical physiology courses. We're adapting to that, and you've seen we've started the last couple of years several significant neuro classes in the department, something called practical neuroscience, where they do lab work to learn the basics of neural physiology, and there's several others, some of them taught between psychology and biology departments. But anyway, if you're interested in the area, which is a highly evolving area, it's all kinds of new courses, even courses which are being taught up in Jupiter, making use of our connections with Max Planck and so forth. So we're definitely expanding the neural offerings of the department as we hire more people in the area. But anyway, moving along. So this material can't be read about very well, so I'm just going to give kind of an introduction to each area. If you want to read anything more, you can, probably the easiest source is just type in things like EEG into the internet, where we get all of our information these days. But I just want to give you just a basic information about a couple of things. Today we'll talk about EEGs and sleep, which are two kind of interesting phenomena that have important ramifications as far as us and the nervous system. So EEGs is a recording made by very sensitive voltmeter, essentially measures potential changes on the surface of the scalp and designated areas, very well described areas. They're standard, and what they usually have is a kind of cap that fits over the patient's head with the electrodes sewn into the cap. And it's used in clinical neurology. It's used to diagnose epilepsy and various other diseases. Not awfully a lot, but definitely a tool which we can use to gain some information. The wave patterns are not generated by action potentials in the brain. They're generated by many EPSPs and IPSPs. In other words, it's the sum of a tremendous amount of currents from these large pyramidal cells that are located in columns in the cortex of the brain. So you're just summating a tremendous amount of activity. You're not definitely recording any action potentials. And what you're looking at is not so much the size or even whether these waves are negative or positive, their polarity, but the frequency. What seems to be more valuable in the EEG than anything else is the frequency and where the wave patterns are generated from. So that's what I'll focus on, is just how we determine the frequency of the waves and what alters that frequency, and definitely polarity and size of the wave patterns is not that important. So the frequency is affected by our age, and I'll go through that when I talk about the different frequencies, but definitely young folks have much slower wave patterns than we do as we age. Maybe their thought processes aren't as complex. Definitely how alert or how conscious we are, where the recording is. We can get what we call evoked potential changes by recording over the occipital lobe or the visual cortex, for example. Drugs definitely can affect the reflex, the frequency of the wave pattern. Most notably, anesthetics can really slow down the wave pattern, and definitely different neural diseases can affect, and especially use of drugs can affect these wave patterns. So, just an introduction, there are 4 very general classification of wave patterns, primarily based on frequency. So, wave patterns from 8 to 13 hertz we classify as alpha waves, and that's recorded from a person that's just totally relaxed, that is just kind of sitting there and not focusing on anything, just in a relaxed state. They used to have something called an alpha generator that they could have, that patients or people could purchase and put a couple electrodes on the occipital part of your brain and have you just relax and try and get the buzzer to go on. And the buzzer was calibrated so it'd go on when you were had an alpha rhythm. And the idea was to see if we could train people to relax more. But anyway, it's the type of wave pattern and seen in a completely relaxed individual. Whenever you become more involved or active from there, you go into what's called a beta rhythm. So a beta rhythm is a frequency higher than 13 hertz, and when you're doing any mental or even physical activity, that's the type of wave pattern you have, even significant sensory input, like you're sitting in a concert. So any type of activity leads to beta type waves. So I guess I never did that. Okay, so the next wave pattern is theta, and theta waves are they're slower than is the case of the first wave. So I don't have these going from slow to fast or fast to slow. So the alpha wave is let me go back to make sure you get his point. It's 8 to 13. If you go frequencies less than that, we call it theta waves. And these are observed in young children. That makes my point about very young children have slow waves, but also in people with some mental disorders and right before you get to profound sleep. So this is a much decreased mental activity. And finally, delta waves are less than 4 hertz, so these occur in adults only in the deepest of sleep, but they can occur in very young toddlers when they're awake. So it's a very slow wave pattern of less than 4 hertz. So that's the 4th, most common wave patterns observed. If the EEG is isoelectric, we call it brain dead, or it can occur in severe use of depressants or administration of severe depressants, but persistent isoelectric EEG without depressants is what we call brain dead. This is just the whole cascade of EEGs, starting with the slowest up to the fastest, and the characteristics of them. Grand mal seizure, or tremendous frequency, occurs with seizures that occur in epileptics and other patients. Another thing that you can do with an EEG is evoke changes, is give a stimulus to a patient, usually a sensory stimulus, and monitor a inflection that occurs in the wave in response to this. It's pretty gross as far as what we can do with it, but it is used to determine if some sensory pathways are still present or haven't been damaged. So they can give a patient a bright visual stimulation or a loud noise or even cutaneous stimulation, and monitor some change that occurs, a small little blip in the EKG in response to that. Then the other thing I wanted to do today is to talk about the sleep cycles and a little bit about the cycle that we all go through called the circadian cycle, which is our 24-hour cycle that we all daily go through. And we're going to talk especially the endocrine system, the second semester, about how this cycle is controlled and how important it is for our normal health. It's not quite 24 hours, it's more like a 25-hour cycle as it's been studied. If you put somebody in a totally dark cycle and have them establish their own activity, it turns out it'll end up resolving to a 25-hour cycle. But often we mess up our normal metabolism and all the things incident like this, and one of the things is the spikes of several hormones are on this diurnal cycle, and if we change time zones or the work shift or how our activities are on a day-to-day schedule, it can really alter us in many ways. We can end up with very confusion in our mental processes and being tired when we shouldn't, and on and on. So it's definitely our well-being is affected by maintaining this cycle. Part of the cycle is sleep, and we can describe sleep, and people have studied it for many years in sleep labs in different forms. For example, we divide sleep often into REM, standing for rapid eye movement sleep, and non-REM sleep. Non-REM is when we first lie down to bed at night, our muscles relax. We have indicators like a decrease in heart rate and gastrointestinal activity, mainly the contractile activity of the GI tract. And those EEG waves, which we talked about, start slowing down and becoming very synchronized. In this earliest sleep stage, we can be easily aroused without any loss of confusion. Without any confusion, we can wake up and just go right on. REM sleep, in contrast, occurs a little deeper into the sleep process, and they call it REM because if you look at a patient's eye in that stage of sleep, there's some rapid eye movement going on. And normally in a normal sleep cycle, it occurs about every hour and a half, and not only the eye muscles can move physically, but also other muscles. People move their legs and other muscles of our body, but most of it's characterized by this eye movement. There are some changes in temperature, and heart rate, blood pressure, and respiration that change up and down in this cycle, and the EEG becomes less synchronized, and I'll show you some figures of that. And this is the dreaming stage, and some of the some of the changes in heart rate and so forth have to do with the dreams that are going on. So here is EEGs recorded during these different stages, and the different stages here aren't classified. These are all non-REM, these stage 1 through 4 is non-REM sleep, and down here is we call REM sleep. So stage 1, the patient is, you get home and you sit in front of the TV and you're watching TV and you go nodding in and out. You're not planning on going to sleep, but this is kind of your drowsy stage, and that's where you start having the theta type activity. So that's the initial stages of going to sleep. Light sleep is characterized by very distinct EKG figures. This spindle or very tight wave followed by slow waves on each side. It's called the spindle, and also these great big K complexes, they say, are large amplitude waves, are also interspersed in people in this stage 2 sleep. And finally, stage 3, you can get into delta waves periodically, and this is a most deep level of, not the most sleep, but going into the deepest sleep when you have total delta waves. And now the muscle tones really relax, the heart slows, and you have periodic delta waves, and the only difference from the deepest sleep is you have constant delta waves. When you're woken up in this stage 4, it's really confusion, and you're really hard to wake up when you're in that deepest sleep stage. And finally, if you go back into REM, and periodically that every 90-minute thing, you go into a faster theta activity and even beta activity during REM sleep. So this is supposed to be a typical person's sleep cycle. So this would be 8 hours of sleep in a person, an adult individual. And so this is sliding down from awake to stage 1, 2, 3, and 4, the deepest sleep, within 30 minutes or so of when you lay down. And then, as you see, you go back up into the dream stage of the REM sleep. So these cycles occur 3 or 4 times a night, where you'll go down into the deepest stage and then come back up in some REM, and then you go down to the deepest stage, and on and on. And where the infant, the newborn, will spend a lot of time in these studies in REM sleep. As we get older and older, we spend less and less of our time in an REM pattern, and you just go up and up beneath this stage. But anyway, it's kind of interesting. So the deepest stages of sleep are in the first few hours, and this has been known for many years. I remember hearing about this when I was in college, and I got this bright idea because I had to study so much that I could sleep for 2 hours and then wake up and study and then go back to sleep for 2 or 3 hours, and I'd have 2 of those deep sleep things, and I'd put my study in the middle of it. I tried it for a year or 2 and found out it just totally wrecked me, so I wouldn't suggest. I don't know why. We don't even know why we have to sleep, but that didn't seem to work in my physiology. So we don't know exactly, other than whether when you don't sleep, you're very become confused and debilitated and so forth. But we don't know exactly the purpose of it, but you certainly have to have this activity in order to stay in good health. And as you all know, what's going on in your life affects your serotonin and your levels of both sympathetic and parasympathetic neurotransmitters can really affect the sleep cycle. And so the stress in your life and so forth can really play havoc with your sleep. And we'll talk more about that when we get to stress in the endocrine unit. So anyway,